Thank you, Oakland County EMS providers, for joining us for Section 2 of the 2024 protocol rollout for the new protocol suite that will be implemented on February 1st, 2024. Thank you for joining me, John Toit, EMS System Manager, Bonnie Kincaid, the Executive Director of the Oakland County Medical Control Authority, and Dr. Gedalia Cooper. Dr. Cooper is our Deputy Medical Director, and we're so glad he's here today to join us. So this is the second series in the protocol suite changes. This is Section 2.2. We have Dr. Cooper here joining us.
Hello.
And Dr. Cooper is going to highlight the changes as we go through these protocols. So we're going to start with Protocol 2.2, Dr. Cooper. Do you have anything that's interesting on 2.2?
So it looks like in Protocol 2.2, the things that are different from what we had previously is that the order of the specific injuries has changed. So it might look different when you're looking at it and you're looking for a specific. Also, it looks like they've taken out titrating the oxygen percentage from 94 to 99% for the traumatic chest injuries. And now it just says just to administer high flow oxygen, which is nice because now you're not having to worry about, what exactly your number is and just put the oxygen on them and move on to your next thing that you're trying to do. Also, under abdominal injuries, they have references to shock in the new hemorrhage protocol, which we'll talk about a little bit later for the hemorrhagic shock protocol. And under head injury, they want you now to avoid hypo or hyperventilation on these patients.
Those are pretty simplistic changes, and you're going to find most of these changes are pretty simplistic. There isn't a ton of changes to treatments in these. It's mostly changes to format and structure, but there are a couple important ones in there, like the oxygen no longer having to titrate 94 to 99% for trauma. For trauma is the key there.
Yeah, and I think that's nice because when you have a trauma patient, you don't want to have to be worrying about watching the monitor for the pulse ox, 94 to 99%. You want to just throw oxygen on and move on to your next potentially life-threatening problem that you need to address.
So the next one we got is burns, Protocol 2.3.
All right, so for Protocol 2.3, under burns, one thing that the state wants us to remember and to realize is that we're not going to count superficial burns as part of the total body surface area burned. Also, they've added the burn severity definition, where you have superficial, partial thickness, deep partial thickness, and full thickness.
And then they got that reference that you guys have seen in Section 1 that goes to the pediatric patients. Listen, that's in a lot of protocols. Just know that that's there. Use the MIMEDIC cards for somebody under 14.
Yeah, and that's going to be a recurring theme throughout all of these protocols, is that they want you to reference the MIMEDIC cards for the appropriate medication dosages. There was also an added line, which, I think goes without being said, but number 7 under general treatment, it says assess and treat for associated injuries. I think everyone's probably doing that already, but they put that in there as another thing for us to consider. Under thermal burns, we added to cover the burns with a dry, clean dressing to prevent hypothermia. This is pretty much a lot of what we're doing in the hospital also. We're just putting dry dressings, sometimes wet dressings, but a lot of times dry dressings on these patients. Under chemical burns, they added to identify the chemical agent when possible. It's always nice to have that information if you're able to get it from the scene, because it'll be much more difficult to get that information once the patient's in the emergency department. So always nice to get that information if we can get it. During the decontamination process prior to transport, it just refers to Protocol 10.8, the Hazard Contaminated Patient Special Operations Protocol. And moving further down, for all types of burns, they put a line in there: if the patient remains hypotensive, consider other underlying causes for hypotension and contact medical control prior to further fluid resuscitation. And I think this kind of goes along in the same lines of assess and treat for associated injuries, which I think everybody's doing anyways, just, gives you that reminder that if something doesn't seem right for other things, and try to treat those. There's also a line added for non-superficial burns without hypotension. Under transport, the transport part of this protocol, another reminder that I think people do anyway, but if there's severe airway or breathing compromise that cannot be managed, please transport this patient to the closest facility. And then there are also some added considerations where one should consider transporting directly to a burn center, and that's in subsection C. There's a bunch of added considerations.
Bonnie, where are our burn centers at?
We just have actually none in Oakland County. You need to go down to Detroit or Ann Arbor to transport your burn patients.
And if you ever have a question or concern, it's always worthwhile to call medical control because we are there all the time, 24/7, able to help make these decisions. One thing I just want to point out is when I was looking through this protocol, consider transporting directly to a burn center if. We always have to remember these are going to be some pretty sick patients. And for example, in where it says full thickness burns or suspected inhalation injury, you always want to still consider, is this patient's airway compromised? And don't get pigeonholed into saying, oh, this patient needs to go to a burn center. If you're worried about the airway, just go to the closest facility. And then we can always send from there to a burn center once the patient's airway is stabilized. The patient with suspected inhalation injuries, even though from the outside, that you might not see major burns, they could have severe burns inside of their lungs and their airway could be at extreme risk. So those patients, really, you should consider going to the closest facility.
Excellent. And now we move on to Protocol 2.4, the General Crush Injury Protocol.
All right. General Crush Injury Protocol. Again, we have here a reference to pediatric patients utilizing the MIMEDIC Cards for appropriate medication dosages. Albuterol has been moved up the algorithm for these patients. Albuterol is used when you're worried about hyperkalemia, which is something you can see with a crush injury. We utilize albuterol in the hospital for hyperkalemic patients. So that's been moved up the algorithm. And if it's a prolonged extrication in a crush injury patient, then there is here to administer sodium bicarbonate. And that just helps drive the potassium back into the cells. And again, temporize if you're concerned for hyperkalemia in these patients.
And that's really it for that protocol. Not a ton of changes.
All right. And then soft tissue and orthopedic injuries. We got the recurring theme of utilizing the MIMEDIC Cards for under 14 years of age for appropriate medication dosaging for these pediatric patients. There's also a reference, and again, this is also something we see throughout. There's also a reference to the bleeding control protocol, which is 2.13. We also have a reference here under number 4 for uncontrolled bleeding with hemorrhagic shock. See the appropriately named hemorrhagic shock protocol. And then there is one part of this protocol here for open fractures to administer antibiotics. We are not going to do that at the OCMCA. Some of the other counties did choose to accept this. In the OCMCA, we did not take this on as a protocol. And the reasoning behind that is because in our county, our transport time to almost all of our facilities is very, very quick. In a patient with an open fracture, they more than likely have significant other injuries. Therefore, to artificially get these medications on board quickly when it can be done in the hospital, potentially ignoring other major injuries, was felt to be counterproductive. And therefore, in our county, we're not going to utilize antibiotics for open fractures.
But we do want to remind everybody that you will find that antibiotic in the drug box because we share that drug box amongst 9 MCAs. So it'll be there, but we will have a reference protocol way back in future section about it's not used in Oakland County.
The Spinal Injury Assessment Protocol 2.6
has no change.
That is amazing.
Which is a beautiful thing.
You're not going to find many like that.
Yeah.
Now, this was the one that I found particularly interesting, the Traumatic Arrest Protocol. It became much more robust.
It did become much more robust. There's some major changes to the structure of this protocol. It's much more thorough, so please really review this one. There's a lot of references to other protocols, as you could imagine. you would have in a traumatic arrest that could be from multiple different etiologies, multiple different causes. So there's a lot of references to other protocols. So please just make sure that you review this protocol. The main thing with traumatic arrests is let's just get the patient to the hospital where we can do a lot more interventions, just rapid transport, load the patient up, and let's get moving to the hospital.
I found the interesting part of this one was the termination of efforts section. Is there anything you want to comment on the termination of efforts and when we shouldn't terminate efforts?
Termination of efforts should be considered, it says here, in blunt traumatic arrest with asystole, no signs of life for greater than 10 minutes of intervention, if you have a transport time of greater than 15 minutes or injuries incompatible with life.
I don't really understand that injuries incompatible with life thing. That seems awful subjective.
Oh, injuries incompatible with life. I think if you would have, someone who was decapitated, somebody who had brain matter on scene. But I also want to say, if you ever have any questions, is this an injury incompatible with life? Should I be transporting this patient to the hospital? Should I really wait on scene for 10 minutes to see if there's a sign of life or not? Call medical control. You'll never get into trouble calling medical control. That's why we're there, to give the advice.
And again, this is just for trauma. This isn't for medical. Medical is completely different, a whole different road you go down. Drowning and submersion injury, 2.8.
All right, so we got some changes to this one. The biggest change to this one is it's changed the water temperature pretty significantly. So it used to be that we had 43 degrees Fahrenheit as our temperature. Now that is changed to 70 degrees is the cutoff point. So cold water is anything less than 70, and warm water is considered anything greater than 70. So that's the biggest change in this protocol.
Well, that's pretty simple. That's basically most of the water in Michigan is cold water.
Right, it's cold water. There you go.
Poisoning, overdose, environmental exposure, protocol 2.9.
In this protocol, it refers directly to another protocol, to the nerve agent organophosphate protocol. We again see under general management of toxic exposure, where you have for pediatric patients less than or equal to 14 years of age to utilize the MIMEDIC cards. We also see here for calcium channel blocker overdose, contact medical control, consider calcium chloride. That's a change to our protocol. And then for other medications, overdose, beta blockers, et cetera, other things, just contact medical control for further guidance.
This was the particularly most interesting part discussed in protocols, and it's going to be discussed at length going forward. I don't recommend bringing the spider, snake, or scorpion to the ED. That seems interesting.
So the protocol now says protect the rescuers, but then bring in the spider, snake, or scorpion if captured and contained, or if dead, for accurate identification. I can tell you from the emergency department perspective that that's not really going to be helpful for us. I would argue that protect the rescuers is number one in this protocol, and don't, go trying to catch whatever the offending animal or bug or whatever it was here. If you really want to do this, take a picture. That's probably plenty. It says here, dead snakes can reflexively bite after death, ensure the animal's dead. I would just say, go with number one, protect the rescuers. And I think you're covered there, just saying, you know what, we wanted to stay protected and we did not need to bring this to the emergency department, because it's not going to be terribly helpful to us in the acute setting.
And that's really all the changes that were in that protocol. How about heat emergencies?
All right, heat emergencies. Using the MIMEDIC cards for patients less than or equal to 14 years of age. It's a common theme here. When that's unavailable, utilize the dosing listed in the protocol. You should utilize the dosing listed in the protocol and otherwise utilize the MIMEDIC cards.
Really, there's not a whole lot that's too earth-shattering in this.
Yeah, there's references to some other protocols, the nausea vomiting protocol. Under heat stroke, here we have the initiation of aggressive cooling may take priority over transport. contact medical control for further cooling and transport guidance. Again, if you're ever unsure about what to do, just contact medical control for guidance. We're here to help you, to back you up, to help make these decisions.
Protocol 211, hypothermia frostbite.
Okay, so not really a whole lot here that's changed from our protocol. It just directs you for hypotensive patients to go to the shock treatment protocol. So this protocol, moderate and severe TBI, just to point out initially, there's 4 clinically important identifiable conditions that we want to be able to identify and treat with this. Number 1 is hypoxia, hyperventilation, hypotension, hemorrhage. Really, in looking through this protocol, it's a lot of words and a lot of noise that's basically telling you to reference other protocols. So this protocol, you're not really going to follow this protocol all the way to the end, because you're going to get to a point in this protocol where all of a sudden you're on another protocol. Familiarize yourself with this protocol, but understand that there is going to be a different protocol that you're going to more than likely follow at some point during this protocol, because if you look, there are a lot of reference protocols in this protocol.
So this is the BCON protocol, protocol 2.13. This one works in conjunction with the soft tissue injury protocol.
And again, with this protocol, it's a relatively short protocol. I think a lot of it is just very intuitive. There's a lot of other references to other protocols in this one. One of the main things to point out in this protocol is for extremity bleeding, you can apply a second tourniquet. There is a tourniquet application procedure protocol that it references there. So again, with this protocol, at some point during this protocol, you're going to reference another protocol that you're going to follow, mainly for the bleeding control.
And the last one is the hemorrhagic shock protocol. This was split off from the standard shock protocol where we used to cover hemorrhagic shock, and now it's been moved into its own treatment section.
So again, a theme with this protocol is there's a lot of references to other protocols here. So at some point during this protocol, you are likely going to branch off into another protocol. I think it's important to point out that no intervention should delay transport. I think that you should try to make sure that if there's an area of hemorrhage that you can control, and that may delay transport a little bit. I think that's important to control the hemorrhage. You don't want to transport someone who's actively hemorrhaging with somewhere that you can control it.
This protocol is also where tranexamic acid lives now. It was removed from the shock protocol and brought specifically into this protocol because it should only be used for hemorrhagic shock patients. And then the last protocol is the sexual assault protocol. This protocol addresses the sexual assault patient, as the name indicates. It talks about some specific injuries that could be sustained during a sexual assault that the provider needs to care for and have knowledge of. It also reminds you to go to the crime scene protocol and reminds you how to care for the clothing so that the clothing is preserved so that the person that allegedly did the assault can be captured. Provide you some resources to give to the patient so the patient can have some resources, and remind you of what documentation is necessary. Well, Dr. Cooper, thank you for coming for this section, and Bonnie, thank you for helping out.
Thank you.
Thank you, EMS providers, for listening. The next section is Section 3, the Adult Treatment Protocols with Dr. Stephen McGraw.